Zoom and also TV. You know, the Asia Pacific Spine Society, founded in 1979, is committed to the advancing spine care, and today's session exemplifies that dedication. Our central themes for this afternoon is advanced spinal endoscopic techniques, an area of rapidly evolving innovation in our field. First of all, I'd like to acknowledge the hard work of our committee, Chairman of APSS Education Committee, Dr. Ajoy Shetty from India, Chairman of APSS Online Education Subcommittee, Dr. Niraj Vasavada from India, in making this event possible. We are honored to have a truly distinguished, yeah, thank you for the Dr. Shetty and Vasavada from the chairman of APSS Education Committee and Online Education Subcommittee, respectively, in making this event possible. And also, we are honored to have a truly distinguished international faculty with us. I'd like to specifically welcome our esteemed faculty members. Firstly, Dr. this is a moderator, Dr. Meng Huang Wu from Taiwan, and Dr. Wu Peng Hong from Singapore, and Dr. Kenyu Ito from Japan, and Dr. Harrison Kim Hyeun-Sung from Korea. We also welcome our dedicated case presenters, Dr. Asrafi Rizki Gatam from Indonesia, and Dr. Ayush Sharma from India. They will share invaluable clinical insights. Our program will be expertly guided by our moderators, Dr. Wu Peng Hong and Dr. Niraj Vasavada. Thank you all for logging in. We look forward to highly engaging and informative session. Now, I hand over to the moderators who will start this session. Please, Dr. Wu and Dr. Niraj Vasavada, please.
Greetings, everyone. I'm Dr. Meng Huang Wu from Singapore. It's our honor, our pleasure to be able to host this as a moderator of this seminar. Welcome the Niraj as well, who is joining me as our fellow moderator. We will kickstart the program with thank you, Dr. Yong-Chan Kim, for introduction and the program overview. Today we will have an advanced endoscopy. So the first speaker is Dr. Meng Huang Wu. He's from Taiwan, and he's a very famous endoscopist in Taiwan who is going to share with us endoscopic cervical foraminotomy. Please, Dr. Wu, Professor Wu from Taiwan.
Thank you so much. Thank you, Professor Wu, and thank you, Chairman Professor Kim. Thank you so much for that invitation. I'm Dr. Meng Huang Wu. Please allow me to share my slides. Yeah, thank you. And I want to spend a few time to discuss, maybe share some updates about the current advance for the endoscopic cervical foraminotomy and discectomy. And I very honored. Now I'm currently the chair of the fellowship subcommittee of APSS. I was trained in previously in Yong-Chan Kim Hospital, and now I'm also learned a lot from various APSS fellowships and AO spine fellowships. So this is my disclosure. And we already know cervical radiology has been advanced now using anterior and posterior surgery that can deal with minimally invasive solutions, especially like endoscope. Now it's so popular to use minimally invasive small incision and keyhole surgery to treat with the lateral lesions. So the previous gold standard is like a tubular retractor with a microscope. You can clearly show the etiology and decompress and achieve a good result. And now we can also use the same method, but with the endoscope. So the foraminotomy actually now has very good evidence showing the result can be as good as even better than ACTV in some way. But mainly the pathology need to be focused on the lateral to the spinal cord. So the indication nowadays is still a bit limited to lateral intraforaminal disc herniation, foraminal stenosis, or lateral recess stenosis. So regarding to the grading, I think getting more familiar with this MRI with the oblique view, so we can see that with the grading, this is a grade 0 and grade 1 with some mild stenosis with less than 50% of root compression, and with more than 50% is grade 2 and 3. This type of stenosis mainly cause symptoms that may lead to surgery. And also the Kim's grading system is commonly used for axial cut that we see just lateral recess, and also the foraminal region can usually have the pathology that we can use the simple decompression to remove the bone posterior to the pathology to get enough space for the nerve root to achieve the symptom relief. So the PCF and PCD nowadays is already popular and can use the power drills, and also even some use a bipolar endoscope to achieve the same result. So the decompression now is quite relatively simple. So actually, there is already good evidence showing the result. It's in the 2020, there is a meta-analysis comparing PCF and ACDF. You can see that PECF with the clinical outcome is similar and even better in the change of FES score, including arm and neck, and also the NDI improvement, and also the reaperture rate and complication rate, they are relatively lower. So I think nowadays, if with the right indication, it can be a good alternative to ACDF. So again, let's take a look at the indication again. About foraminal and lateral herniation from the stenosis affecting C2-3 to C7 to T1, single or multiple levels, or synovial cyst, or some residual symptom after ADR or ACDF. Now you can consider to use this method. Some relative contraindication like isolated neck pain, or instability, or deformity, or cervical disc herniation calcification, myelopathy, and also some canal stenosis. This may use the other method, like nowadays it's popular to use bilateral decompression. So with the initial preparation, with the right patient, you can let patient have a prone position using a natural position and side flexion, and use a Mayfield or Happing, depends on patient's anesthesia status. And also use a clear AP and lateral view to make sure it's not the wrong level, because for a beginner, sometimes it's difficult to localize the lesion on the lateral view. And you can choose standard scope or with a stethoscope. So it's better to be 1 millimeter punch prepared, because we don't want you to squeeze the nerve, and you also need a curate hook or probe. And with the uniportal, the target will directly located to the V point that we can see. It's just the interlaminar window junction. So we can start with a long needle with a guide wire. I personally like to use a guide wire because you can reduce the time to insert the dilator. And also when you enter that fascia, you might need a horizontal cut again, because it's a tighter fascia compared to lumbar region. And for the bipolar, you can use a similar way targeting to the V point, but if you are on the right side of the patient, you might need to slightly put your port caudal to the to the design, because it can allow you have a better control for your instrument. You can also use two long needles to help with the targeting the V point. About the surgical steps, only 4 steps. They're very simple. First, remove the soft tissue with bipolar and with the drill. Expose the V point and try to detach the flavin and prepare the flavin well. And usually, if the patient have an extended neck, the V point may be a little bit medial. So when you prepare, just be careful not to extend the neck too much. Then you will need to cut a lot of bone to see the V point. And then second step, you need to do the laminopharyngotomy with the diamond drill, thinning the bone, but without going through the bone, because this flavin is usually thin and can cause urostomy if you drill too much. So for the beginner, it's safer to stay just only the surface of the cortex, and then you can gradually use the probe to remove the flavin and detach it from the lamina. And if you are doing a wake surgery, this step you can that the patient know you are probing, because the patient will give you feedback. Yeah, they will have some sense of electricity, and you need epidural anesthesia sometimes. And for the location for the V point and the lateral margin of that dura sac, usually it's about 3 millimeter away from the V point to the lateral border. But if you are looking at higher level disc like C34 or C45, sometimes the root is directly located with the V point and also directly same level with the disc. And if that's C67 or C71, then your V point may be inferior to the nerve root. So if you need to decompress the nerve root, you need to go a little bit cranial. So similar, if you are removing the disc, it will be relatively easy because you're going to the axillary part of the nerve root. About the third step, we need to expose, and it depends on the situation. If you need to remove the disc, then just gently retract and do the discectomy with the annulotomy. But avoid too much spinal cord retraction, because it can lead to some neurologic deficit, no matter it's transient or permanent. Just avoid too much spinal cord retraction. And also the fourth step is decompress pedicle to pedicle to make sure the whole foramen was decompressed. And it's usually 4 to 5 millimeter from the lateral border of the dura sac is enough for the decompression. So the final step will you can consider hemostat and put and drain, depends on your the patient status. So this is case demo like a C56 hernia disc with a reticulopathy. The patient, we did a awake surgery. The patient was strong and
OK，这是你写的歌单然后
local
对，
anesthesia
好，
injection.
待会重复播
And
放。
then we will start to find the V point and then decompress the brain. And before the surgery, we usually give
这是你写的歌单然后
and also the neck organ
待会重复播放。
6% of to allow the patient to feel better. And with the V point targeted, then we start to do decompression like this. First, see the V point, and then gradually remove the thinning the bone, and you can see some perineural tissue. Usually at that point, the patient will not feel discomfort. But if you start to use the Carrison punch, if you don't use 1 millimeter Carrison punch, that can lead to some discomfort of the patient, especially when you decompress the lateral recess. The area will be more discomfort. So for this, usually if there's a disc herniation, if you need to remove the disc, sometimes you need to do general anesthesia because the patient won't be too much discomfort. So after doing the pedicle to pedicle confirmation of that release, then you will end the procedure. So the symptom usually can improve right away after surgery.
OK，
And if it's
谢谢医生
好，哎，活动都很正，好，起来，棒，那这样我开始，
然后你就两手抬高 ，OK， 然后两手
OK，
握拳，
那一切都还
好
好，，
然后你就
OK。
Okay, so the other case I think will be similar, but it's a case with previous ACDF. The patient have a fusion, but after 5 months still have C5 dermatome discomfort and reticulopathy progressive pain with, after two months. I think that's related to some incomplete decompression of the foramen region, and the symptom was confirmed with MRI that we see the lateral recess stenosis and also the selective nerve block with the C5-6 block. And then also the CT scan can also again see the foraminal stenosis region. And then we can choose the same procedure with the foraminotomy from posterior to decompress the foramen. So this procedure is quite well studied, and it can be compared between three procedures like uniportal, biportal, and microscopic surgery. And among these surgery, biportal seems to have a longer operation time, but it's still acceptable. And you can see the outcome, they are similar. And also the facet resection for the uniportal surgery seems to have the least resection, can further maintain better stability. But I think three procedures, they all can maintain the stability well. And about complications, usually there's similar complication profile. And for the full endoscopic group, they have a higher transient root palsy, may related to retraction or water pressure. And but generally it's manageable. But still need to be careful about the steep learning curve. So about the recent meta-analysis all showed similar good outcomes. So cervical endoscopic surgery improved both cervical and radial pain, high success rate, rapid recovery, minimal readmission rate, and occipital complication rate. And if we want to avoid the complication, C5 palsy can also be avoided with if that's a weak patient. So some series mentioned nerve root disturbance, thermal injury that need to wider posterior decompression, or the foraminal width less than 3 millimeter, that will lead to some chance of C5 palsy, so can be avoided in the future. So nowadays, there's also case reported about a weak surgery with the decupit position. So I believe this can avoid some complication like a C5 palsy. So the current advantage for this procedure, we see this is a motion preserving surgery, very good patient's outcome, and but must be right indication. And the learning curve still there, but also chance to have a vertebral artery injury, but generally can be manageable. So thanks again for allowing me to share. I believe through the efforts of APEC and global collaboration, endoscope, and also advanced technology can further help the patients all over the world. Thank you so much.
Thank you so much for Professor Wu. We will leave the Q&A at the later session. Maybe, okay, maybe we can give some time for question and answer session since we are still ahead of time. Anyone have any question? I have one maybe for Prof. Wu, to start the question. Actually, I have one case. I thought that he has a C5 palsy, but it turned out that he has a rotator cuff tear. What are your tips and tricks in looking at differential between the calf, because especially we take the shoulder down and then versus a C5 palsy.
Yes, thank you. I think the differentiate must be made before surgery, because like when we diagnose the radiculopathy, we also need to do an EMG and CV, and also do selective nerve block, and also the physical exam definitely can help. I think those can avoid that the the bad outcome after the surgery. And also, I think some patients have both lesion. So they have the cervical lesion and the rotator cuff lesion at the same time. So for those patients, we can explain earlier to let them know we are treating them for the neurologic symptom first, and then the shoulder problem can be later. Yeah, depends on the severity of the disease. Yep. So that's my current suggestion.
So the faculty and participant do text if you are, or you can raise hand and ask the questions. Thank you, Prof. Wu, for a good answer. Any further questions?
Can I have a question? Can I ask a question,
Yes.
Dr. Max?
Yes,
Yes,
yes.
thank you so much,
And
Professor Kim.
nice to see
Thank
you
you.
again. Very
Yes,
nice
very nice.
to lecture and presentation. So I have just a simple question. So, the ability to perform this decompression under high magnification by endoscope is a key advantage of the endoscope. However, the achieving adequate bony decompression of the uncinate process in case of severe lateral recess stenosis still remains a significant challenge for even the most experienced endoscopic surgeon like you. So my question is, how do you manage the risk of post-operative C5 palsy as the severe lateral recess stenosis? What specific decompression and point do you use to ensure adequate nerve root mobilization without causing excessive traction?
Yeah, thank you so much, Professor Kim. Yeah, I think for severe canal stenosis, those cases, if the endoscopic compression still may remain challenging, especially for the anterior lead pathology like within the process. So from posterior, the decompression can only do like for the mild, not to two severe cases, I think I would suggest for those for this type of surgery. And for the severe case, I believe anterior surgery still will be needed. And for the avoidance of the C5 palsy, I believe with the endoscope, it's actually limited decompression. So that can relatively reduce the chance to have a nerve root posterior shift, but it still can not complete avoid the C5 palsy. So but mainly it's a transient neurologic symptom. But the other way is to awake surgery that we perform now. The patient can give you feedback when they feel discomfort during the procedure. Then further can reduce the chance to have neuroproxia, nerve injury after the surgery. So I think that's a way to avoid that as well. And yeah, I have to say, endoscope foraminal probably still not suitable for all cases, but it's still good for some case who just need a precise targeted decompression.
Mhm. Mhm.
Okay, if there's no further question, I would start my second talk. So today, my talk is on thoracic endoscopy for decompression for thoracic ossified ligamentum flavum. I'm from Singapore, and this is my disclosure. I practice as a private surgeon in Singapore in several different hospitals, and I'm a visiting consultant in several clusters of government hospital as well. I do both the uniportal endoscopy and biportal, and today thoracic talk as well will be showing both the uniportal and biportal method of decompression. The evolution of endoscopy has opened up windows of opportunities of treatment of complex spinal cases. We started out by many years ago by experimenting on the discectomy through the transforaminal window and then interlaminar through the lumbar region. And gradually, as we are comfortable and there's a improvement in the lens, the lightings, as well as the equipments of the endoscopy. We have now explored cervical, thoracic, and even lumbar fusion. Previous talk, we have seen Prof. Max Wu talking about cervical. Now we'll be talking about thoracic. Thoracic interlaminar endoscopic unilateral laminotomy with bilateral decompression is a common term that we use in the uniportal endoscopy. I think the thoracic decompression surgery in general has several challenges. First, it is in a close relationship to the pleural and the lung. So if we are not within the interlaminar window, we skirt past it, and if we get lost, there is a risk of getting injury to the pleural and the lung. Second, thoracic level identification is key. So counting levels from either the cervical region or the lumbar region is important to be operating in the correct level of thoracic spine. Thoracic cord does not have any tolerance in terms of retraction, so uh, there's no touch technique involved in thoracic decompression. And in particular, thoracic ossified ligamentum flavum tends to have some dural adhesion that may lead to challenges and may have concern of dural tear. So complication of OYL in open surgery has been reported, such as durotomy, neurodeficit, hematoma, infection, instability. And using endoscopy, you try to minimize the complications by having a better magnification and using saline careful separation of planes to allow decompression and hopefully without any complications. I think the rate of complication has shown in several of the papers to be lower than the traditional open thoracic decompression. Of course, that takes also experience of the surgeon. In talking about OLF, this is a particular condition that's more common in the East Asian population, and there's also a predisposition of thoracic prolapse disc, making this a more challenging surgery for many of us. So the traditional surgery is open surgery, but endoscopic spine surgery reduces perioperative mobility. When we have a ossified ligamentum flavum, we do a pre-op evaluation for the X-ray, the MRI, and CT scan. We'd like to highlight about the CT scan. We'd like to classify them using subtle classification to see whether there is a opening, whether it is a completely linked, completely connected bilateral ossified ligamentum flavum, or there is a window in between the two flava. We also look for a tram track sign and the coma sign to see whether there's dural adhesion. So tram track sign and C sign, for example, can be some signal of the fact that there's dural adhesion. The setup of the thoracic endoscopy is pretty similar to lumbar. Just have to be careful that the thoracic spine should be exposed under a fluoroscopic window, so we can use II to identify the levels. We typically use very similar to lumbar spine that we have described in our neurospine publication on how to do the unilateral laminectomy, bilateral decompression. The main difference is that in the thoracic spine surgery, we need to be more generous in resetting and the spinal laminar junction. In fact, if we have to do it, we do a laminectomy so that we create sufficient space that our Chairperson will not touch the thoracic cord. So we talk at the correct window, usually interlaminar. We understand where is the ossified ligamentum flavum by the CT scan, and then we do a pedicle to pedicle decompression. This is how we start. We start from the ipsilateral side, and then we go to the contralateral side, and subsequently lift up the ligamentum flavum en bloc. So this is how we do this already published under the Operative Neurosurgery Journal. So a couple of years ago. So this is a T56 OLF patient. You can see from the CT and MRI, there's some compression of the nerve. We talk at the interlaminar window, and we do a decompression. So we start with the ipsilateral side. and expose the unlike the lumbar decompression where when we dock we can visualize the facet joint very well and the ligamentum flavum. Thoracic spine tends to be when we dock we just see bone. So we have to drill before we see the ossified ligamentum flavum, which can also look like a bone, however, with very minimal marrow bleeding. Okay, that is a sign that it is a region of the ossified ligamentum flavum. So we first of all create a sufficient space in the ipsilateral side. Also very generous in drilling the spinal laminar junction. You've got to create sufficient space enough for the drill to be looking over to the contralateral side. So do drill quite a significant amount of the spinal laminar junction or even sometimes spinous process so that we can see the contralateral side. So now we have thinned the distal margin of the ligamentum flavum. Then we go up you can see now pass through the midline to the contralateral side, the ipsilateral side to the contralateral side. We find the margin of the ossified yellow ligament, just to speed it up a bit. So now you can see the entire block of the ossified ligamentum flavum. You can see as we draw there. And then now after we clear the distal margin, we can go up to the capillary margin. The same principle we drew till its thin normal junction between the flavum and the OLF. We need to thin down the OLF as well so that we can get to the contralateral side. I typically use the NSK drill. It allows fine drilling of the ipsilateral and contralateral side. Of course, other drills is acceptable as well. But the key is that it should be slim enough for you to visualize the entire drilling process. This surgery is, in my opinion, majority of the work is done by endoscopic drilling. We can be drilling about 90% of the surgery and then just spend the last 10% of the surgery plugging out the 2 ligamentum flavum. So just to speed it up a bit, then you can see that we have now current drill the entire flavum, then we lift it up, expose the underlying dura. And lift it up as an on-block technique can be seen on the left side screen that it can be removed on block. With such technique, the dura side is intact and the decompression is complete with a good CT and MRI showing sufficient decompression. So you can see the pre and post-op and it has been published. So we have to be careful in thoracic decompression. Look at the body physics as well. Some of them are overweight. If we have whole arm, it would be good to evaluate post-op adequate decompression. I will insert during every case. So the second case, I will thank my fellow. Just a quick one on biportal because principle is similar. This is a revision case. The patient had a previous open thoracic decompression, and however, they did not complete the surgery because I suppose there's intraoperative signal change, and it has dropped significantly. A patient was closed out without completion of the surgery. You can see the laminectomy scar in the view here. However, the distally, there's still ossified ligamentum flavum and proximally as well. So we identify the level of the ligamentum flavum. We expand the spinal drilling of the spinal laminar junction using biportal, and very similar principle. We drill sufficiently until the edge of the ligamentum flavum on the top and the bottom. You can see the thin pinkish appearance showing the top and the bottom of the ligament flavor. And then after that, we have defined margin, we expand it laterally to the ipsilateral and contralateral side, and also to thin out the ligamentum flavum. We can use a hook knife or the Chairperson to punch out the edges. Use Chairperson 1, we were to use Chairperson 1, and then decompress ipsilaterally and contralaterally. Okay, in case of a dura tear, we can use the Tecosil gel technique. We have published a paper on how to do that. In this case, we find out the reason why the surgery was terminated prematurely. The patient had a dura tear, so we repair it. This is a minimally invasive surgery, so after we repair the dura tear, the patient we stitch up without drain. With a drain, and then subsequently the drain was removed, and the patient has no further sequelae. No further issue. This video showing the decompression of two levels, one proximally, one distally. And you can see that there's sufficient decompression. Before that, there was a huge LF compression of spine, as we have before. This is the sort of MRI for about 3 weeks. Patient was on wheelchair, and day one he walk. This is 5 days later, before he fly back to his native country. We take a look, and there's no CSF issue leak. He went on to heal very well, and he's now back to work. So these are my two cases, just to highlight the difficulties in OLF, and I would like to hear the opinion and questions. Thank you very much. If Niraj is not here, maybe Prof. Kim can help in moderating for now. Anyone have any questions? Okay, seems that I've taken up a bit more time, so if there's no question, we go on to Professor Kenyu Ito. He's my good friend from Japan. He is a very famous endoscopic surgeon, together with his brother Zanya Ito and his father Fuji Ito. Yes, they have opened up a Japanese market in endoscopy. And today he will be sharing with us lumbar endoscopic fusion. Professor Kenyu Ito, please share your screen.
Yes, hello everybody. Thank you for having me today. I would like to say thank you to Professor Yong-Chan Kim and also Professor Woo Hu and also OrthoTV. So please start my slide. Hello everybody. I'm Kenyu Ito from Japan. Thank you for having me today. I will talk about endoscopic lift from extraforaminal. Extraforaminal approach gives us indirect decompression. First, I started with unipolar, but I switched to bipolar these days. Today, I will talk about that.
My name is Kenyu Ito. Thank you very much for giving me the opportunity to present today. Our hospital is located in Aichi Prefecture, Japan, and we perform not only endoscopic surgery but also scoliosis surgery. Today's topic is lumbar endoscopic fusion. I don't have any COI. Since 2016, we have been performing lumbar fusion surgery using a monoportal full endoscope. This is a method performed via a safety triangle called Cambin's triangle. If there is enough space in the Cambin triangle, the cage can be inserted without bone drilling, but if there is not enough space, the SAP must be drilled to create space. The cage was inserted while protecting the nerve with a retractor, and then PPS was inserted and compression was applied if necessary. This technique is an indirect decompression procedure performed through the intervertebral foramen without seeing the dura mater. As shown in the MRI on the bottom left, sufficient indirect decompression is achieved. If there is not enough bone to graft, an additional small incision is made and bone is harvested from the ilium. A study was conducted to demonstrate the minimally invasiveness of PLIF, using MISTLIF as a control for comparison. PLIF was superior to MISTLIF in blood loss, hematoma, and muscle damage, but transient exiting nervous injury was observed in 3 cases with PLIF. These results demonstrate that extraforaminal LIF is minimally invasive. However, there are reports that inserting a cage through the narrow extraforaminal space can cause exiting nerve injury in 20% of cases. In our own experience, it occurred in 6% of cases. To solve this problem, small, thin cages can be used, but this can also reduce bone union, indirect decompression, and alignment, which is counterproductive. In addition, in the case of a large disc such as L5S, it is desirable to insert 2 cages, and in this case, it is necessary to perform the procedure from both sides. In my opinion, ideal lumbar interbody fusion is one that achieves symptom improvement, bone union, and sufficient lordosis. In addition, it would be ideal if there was no nerve damage, less blood loss, performed by a single surgeon on one side, and furthermore, reduction of radiation exposure. To achieve all of these ideals, we have been developing and performing 3D navigated unilateral biportal endoscopic extraforaminal lumbar interbody fusion since 2023. First, the navigation antenna is placed on the spinous process. Next, a skin incision is made for the PPS. An endoscope and tools are inserted through the skin incision on one side. The SAP is resected cranially from the pedicle. From there, the cage is inserted extraforaminally. This is an image of an actual surgery. A PPS was inserted on the contralateral side, and a pilot hole was dug on the ipsilateral side and a guide wire was inserted. The surgery was performed while watching the endoscope monitor and navigation monitor. Inserting the endoscope along the guide wire made the anatomy easier to understand. The pedicle screw hole was visible, making it easy to determine that this was the transverse process and SAP. Additionally, navigation helps understanding of anatomical structures. Navigation confirmed the presence of the facet joints. Navigation of the chisel, allowing for precise identification of the location to resect the SAP. Advantage of navigation is that it provides an axial view, allowing for safe control of the chisel's direction to prevent it from entering the spinal canal. Under navigation, a paddle was inserted into the intervertebral disc, and after opening it, rodding was performed on the contralateral side. A large space for inserting the cage was created. In most cases, the exiting nerve was not visible. After curettage of the end plate under navigation, bone grafting was performed and the cage was inserted. The axial view allowed for the cage to be placed in the ideal position. The first step was to insert one cage into the L4-5. The cage is L-shaped and creates lordosis. Slippage also improved. The second step was to insert two tall cages into the L4-5 to achieve indirect decompression. The slippage was corrected, the disc height increased to 10 millimeters, and the patient's symptoms improved without direct decompression of the dura. To insert two cages in the anterior-posterior direction from the extraforaminal position, the first cage is inserted contralaterally from the midline, then impacted further to the contralateral side, and the second cage is inserted into the space created. The third step was to insert two cages extraforaminally into the L5S. Using the navigation system, we confirmed that the probes were reaching both the ipsilateral and contralateral sides. Then, using the two-cage insertion technique described, we inserted the two cages to the correct position in the axial view, as shown in the figure. This cage allows for the creation of lordosis because it opens anteriorly. Using this method, lordosis can be created from the extraforaminal region even in the L5S. Two cages provide stability and indirect decompression. Over the past 2 years, we have performed this procedure on 54 patients, approximately half of whom were at L5S. To date, no exiting nerve injury has occurred. In one recurrent case, strong adhesions was observed, so the IAP was also removed and converted to UBTLIF. Cage subsidence was observed in 3 patients, but they fused and the prognosis was favorable.
A CUSM was performed to examine the learning curve, and the results showed that 22 cases were required for the procedure to become stable.
In conclusion, UBE extraforaminal LIF has achieved all of these goals. We will continue to increase the number of cases and develop the technique.
Thank you for your attention.
Thank you for your attention. Please ask anything about this. Thank you so much.
And thank you, Professor Kenyu Ito. It's a wonderful talk. Anyone have any questions? Maybe I have a question for Professor Ito. Once we put in the guide wire, I find that sometimes it might get in the way of the working portal, especially when we want to actually lower our arm to bang in the cage. We will get into the the wires and touching your hands and the wire coming out and things like that. What are your tips and tricks to prevent the wire getting in your way of your working portal? Since it's a small cut and you will have to share space between wire and your instruments.
Thank you for your question. So as I show in the slide, I bend the guide wire to, for example, like this way, so it does not disturb me. But sometimes when I push and pull the endoscope, sometimes guide wire comes out. So guide wire is not necessary, but after insertion of cage, it means that disc height will be get high, so navigation will be different. So I want to put the guide wire first, but if the guide wire is pulled out, it is take one more time navigation or watch the C-arm lateral view. Then I can insert the pedicle screw safely and correct.
Thank you, Professor Ito.
Can I ask a question? Yeah, thank you for your great presentation. So, in spite of that, I'm still not sure for the fusion rate through the endoscopic fusion. I mean, many massive washout of bone graft after the endoscopy procedure. So, actually, you demonstrated successful cage placement through the endoscopic corridor and compared to the open or missed lip, what are your objective criteria for assessing the adequacy of end plate preparation? And how do you ensure the large surface area is adequately covered for fusion in the disc space?
Thank you for question. That's very important question. First, we can see the end plate clearly by end scope. So we can see clear that we remove the bony end plate. And second, for the bone implantation, I mix with the artificial bone, which is a little bit stitchy. So under the water, still bone can remain there. And third, still this is a 2 years my experience. I cannot say the clear bone union rate, but mainly the half case is past 1 year already. And almost case has a facet fusion. Facet. Because I put the 2 cases, it is very stable, so facet will be fused. And as your maybe opinion, I cannot see the clear disc space fusion because the bone is not enough, but because of the stability, facet will fuse. Because I have experience of lateral lift. Lateral lift is has a big cage. It also has a stability, and if you do the lateral lift PPS, almost case has a facet fusion. So of that experience, I don't think bone implantation is not so. How can I say? Is not you do not have you do not to put a lot of a bone. Is it okay?
Yeah, right. If then do you have any specific other bone material, so like a BMP or the DBM? How about that? Just only local bone chip?
Yeah, in Japan, we cannot use BMP. It's
Really?
not
Okay.
allowed in Japan. So just local bone and artificial bone. I mixed up.
Okay, one more question. So, I think you may you have experienced nerve root injury, extending nerve root injury, especially in L5S1. So, given that the risk of L5S1 nerve roots, exiting nerve roots, what specific intraoperative maneuver or monitoring strategy to avoid nerve root injury of L5S1?
Thank you. So I showed two techniques. First with uniportal, and second for biportal. When we are doing uniportal, we experienced 3 cases of damage of nerve root because uniportal we cannot remove the sap enough. It is sometimes difficult by uniportal, but so I switched to biportal, so I can totally remove the sap, and nerve will be a little bit far from the disc. But there is 2 cases the nerve comes to the view of endoscope. 2 cases. At that time, why bipolar is good is one more that we can retract the nerve and then insert the cage. So I watched 2 cases of exiting nerve at L5S, but after retracting nerve, patient said no symptoms about that.
Thank you.
Dr. Asrafi has a question. You flag up your hand.
Yes, I have questions. So, hello, Dr. Ito. What a great presentation that you share with us today. So, I'd like to ask regarding the post-operative pain in your patient. So I've been doing this endoscopic fusion procedure since 2018. So during that time, my experience is that the post-op pain, if we compare, let's say, with lateral interbody fusion and posterior pedicle screw insertion, is still much higher in endoscopic fusion group. And what is your experience regarding the post-op pain? I mean, if do you think that the endoscopic procedure is still worth it if the pain still exists? I mean, if the degree of the pain itself is still higher after the operation compared with the lateral interbody fusion. What is your opinion about it? Thank you.
Thank you for your question. For like a compare with open PLIF and this technique, postoperative pain is very small.
No, I mean lateral like OLIF or LLIF. I found that OLIF procedure has a very minimal pain compared with the posterior procedure in the spine. And I found in my experience that even using the endoscopy, the post-op pain is still higher in endoscopic group compared with the let's say OLIF group or LLIF group. And what do you think about it?
Thank you. I also have a lot of OLIF or XLIF experience. The pain comes from the PPS, muscle bleeding, inside bleeding, and the tension becomes high in muscle. The patient says the pain. So I always put some like a flow seal in the PPS hole. And after the surgery, I pressed 5 minutes to stop bleeding. And then if you do like this, patient says not so much pain. So OLIF and this technique, pain is same because the pain comes from the PPS muscle pain. That is my opinion.
Yeah, thank you, Dr. Ito.
Okay, thank you so much, Dr. Ito, for the wonderful sharing. So now next we introduce our good friend, Mr. Dr. Asrafi. Rizki Gatam is a good friend of mine from Indonesia. He'll be sharing some thoracic spine case for discussion. Take it away, Asrafi.
Yes, thank you, Professor Pahong. Thank you. He's my good friend from Singapore. So today, my topic would be a case discussion regarding the thoracic stenosis. So as Professor Pahong has already mentioned in his presentation that this diagnosis is quite common in Asian people, and also in Indonesia, I found quite a lot of thoracic stenosis in our patient. So the patient that I like to present is a female, 65 years old, with bilateral leg burn and numbness, and she got a feeling of unstable gait. So if you see here on the way she walks, so it's very unstable. So it's quite hard for her to maintain the balance of her gait. And on physical examination, the motoric of lower extremity is 4+ on bilateral leg with hyperreflexia and hypostasia below thoracal 2. And on the MRI examination, you can see that there are two level pathology, and this is at the level of T12, and the other one is at the level of T11 and 12. So if you look here, that the compression is quite severe, especially at the level of T12. And this is the actual cut. On the level of T12, there's the spinal canal is very narrow, so it's already close by the ossification of the flavum ligament. And level of the 11 T12, there's also some calcified, probably some calcified material of the flavum ligament itself. And if we look from the CT scans here, there's a big calcification on the flavum ligament on both sides. And also, this is the axial cut as well. So the questions regarding the case is that what should we do with the case? Is it and whether we want to do it an open procedure or we want to do it a minimally invasive procedure? So probably Dr. Pahung, whether I can just go on with the presentation or shall we have some discussion first?
We just have a few minutes. See the different faculties. What are their opinions? For this panel discussion. So maybe Dr. Sharma, what will you do for this case?
Yeah, I think both the levels they have significant compression. There's no doubt about it. So you need to do a good decompression. What you choose totally depends upon your expertise. If you have enough expertise in endoscopy, we all know the benefits of endoscopy. So I will prefer endoscopy, but because these are very tight canal and there is there's certain risk involved when you do these cases. In my book, we prefer a ultrasonic scalpel. So we have a long tip with the ultrasonic scalpel. So I will prefer using them, especially when it comes to these cases. We find them very, very useful because you can really make a space around it. So that is my way of doing it. You can do it in different ways depending upon your expertise. But in these cases, we either use tubes or endoscopy, but we use the ultrasonic scalpel to go all around it because we find it to be slightly safer than your traditional technique of burring and using the rongers.
So how about Dr. Ito? How would you deal with this is a subtle E, so complete ossification. So there's a chance of a dura tear. Dr. Ito and maybe later Asrafi will show us how would you try to prevent a dura tear in this case, especially in the T12 region.
First of all, I don't want use the Endoscope which with water like a UV or a FIS because the severe spinal cord stenosis, water pressure sometimes damage spinal cord. So for me, if I use Endoscope, I use micro Endoscope, MED, because there's no water pressure, and also I can use both hands. And if there is a durature, I can repair. And if there is a small durature, I do the same technique with Professor Wu, tackle seal.
I personally would still do, and I have done cases like that with biportal. Water pressure wise, we make it very low. It's almost dripping water pressure. Only difference is that you got to be very meticulous in the whole process of stopping bleeding. I still use a drill because I can thin out the OY or ossified ligamentum flavum, so to assess whether the dura adhesion is really tight on the dura. So when we tug on it when it's very thin, when we tug on it if it's very thin and it's stuck, then we may leave an island of bone of the ossified ligamentum flavum. I find that if we just pluck out the ossified ligamentum flavum, in this case, it has two issues. One is we might have a large dura tear. Second one is that you might have reperfusion syndrome, white cord syndrome type of phenomena. There will be a lot of paresthesia. So thinning it out and gently using a hook knife or hook to decompress might be okay. And then I've been doing UB for these very tight cases. It's not easy. It's high risk. We inform the patient about that, and often they don't have really a lot of choices. If they choose UV, then that would be it. Yeah, maybe Asrafi can show us what you do.
Yes. So probably this is also a question, right? Whether this is an ideal case for endoscopic spine procedure. I know that some of the faculty here prefer an open surgeries, and if we look at the image here, you can see there is no space at all in the center here. So it's very hard to identify the structures during the surgeries, and also the ossified fragment might adhere to the dura. Probably there is no space at all between the dura mater and the the ossified fragment. And also on the level below, we can see here there's a comma sign, which is also a sign of possible dural ossification as well. So we might want to be very careful about that. And so regarding the endoscopic procedure, to be honest, I prefer to do it using the biportal endoscopy because of the mobility of instruments and the field of endoscopic view compared with the uniportal, which is slight narrow, the view. So in this case, I did a biportal endoscopy. And so this is the endoscopic video. Sorry. So on the left side, this is the procedures done at the level of T12. So this is a biportal procedure. So my landmark for instrument and working channel insertion is at the level of the pedicle, above and below. So during the drilling process, so we have to drill down everything until we found the calcified fragment under the flavum itself. So usually there's two layers of bone. The one is the superficial part that's located above the ligamentum flavum, and then we see the flavum, ligamentum flavum itself, and directly under the ligamentum flavum, we still see some of the bone, which is the calcified fragment of the ligamentum flavum itself. So we need to drill down everything until the fragment is paper thin. So like this one, we can see that the paper thin calcified fragment has already moved. But in my experience doing this kind of cases, most of the time we could not take out the whole ossified fragment due to adhesion into the dura mater itself. So I prefer not to use the Chairperson ronger. So I try to use the hook. So we can see here that whenever I try to lift up the fragment, the dura also move. Okay, so so if you look here at the center, there's already some of the dural tear because of the drilling itself. So basically, if we see here, this is the calcified fragment that's already ossified into dura. So this is the dural. So right after that, I put some patches just to make sure that there's no dural rig. So on the right side here, this is the video at the level of T11, T12. Also, even though that it is a little bit, if we see from the MRI before, it might seem to be a bit easier compared with the upper level, but it turns out that the ossified fragment is also adhered to the dura itself. So basically, we might want to be very, very careful when using the Chairperson ronger. So like this. So when I try to thin out all the fragment, there is already some dural tear as well. So probably there's already no dural part under the ossified fragment itself. So my opinion for this kind of cases is that first, it's better to just float the ossified fragment other than trying to take out and remove all the ossified fragments. So as you see here, when I try to lift up the ossified fragment, there is no dura mater under the ossified fragment, and we can see the inside of the dura mater itself. Okay. Also on this case, I put a patch in because see there's already dural tear. Okay. And this is the results after the procedure. So we have quite a good space at the posterior part of the ossified fragment, and the fragment is already floats over the dura mater. So in conclusion, that we have to evaluate the MRI and CT scan before the surgery to identify the severity of ossification and whether this is an ideal candidate of endoscopic procedure for decompression. And this kind of for doing this kind of decompression, I think one must be comfortable in managing lumbar and cervical pathology first before moving on to thoracic spine. So thank you. Back to you, Pang Hong.
Yeah, thanks, Asrafi. Wonderful case and difficult, challenging case and outstanding results. Anyone has any questions?
Yeah, just one small comment. If you can try a ultrasonic scalpel instead of a burr in these cases, it really makes your life easy, because if you look at how the burr works, it is a drilling motion, and that's why it is very, very difficult when you are near the dura. But the ultrasonic scalpel works on like it sort of cuts through the bone, so making it floating becomes much more easy, especially if you're doing UB or tubes. You can really put an ultrasonic scalpel and you can make a nice window all around it. And so our experience, we find that especially these cases, ultrasonic scalpel really, helps you do a safer job. Although brilliant work, Dr. Gatam, what you did, brilliant work.
Thank you, Dr. Sharma.
Okay, so
Can I ask
in that
question?
case,
Oh,
yeah, one question, yes. Yeah, please.
I have experience of after the dura injury with the water goes into the subarachnoid, and patient has seizure and like convulsion after surgery. So why I don't want to use the water in this case? Have you have experience of such kind of things?
To be honest, I personally never have experience with that, but most of the time when I encounter a dural injury, so post-op, usually the patient got a headache. Usually, that happens most of the. But to be specific for convulsion and seizures during or after the surgeries, I never experienced it.
I've done removal intradural tumor, open up for a while, and dura, and hook out the tumor, and so the exposure of the intradural nerves to the saline is there, and as long as we keep it very low or almost zero, like dripping, almost like patients with BPH. Very little type of saline usually is okay. Because considering when we do open surgery, we also have our assistant dripping little saline at that rate when we do drilling as well as decompression. So I think that rate is okay. So any high pressure, maybe that may be a problem. I don't have a case like that, but yeah, as a like Rizki mentioned, sometimes we have patient with headache, but more of like when they sit up or change position, they get better over a week. So usually that's the just for a dural repair issue, not so much of the saline issue. But it's been reported in the literature, so it's a real concern. Okay, so let's have moved on to Dr. Sharma for his case presentation and discussion.
Okay. So can you see my slides now?
Yes, we can.
Okay. So thank you for the opportunity. I am Dr. Ayush Sharma. I am a spine surgeon based in Mumbai, India. My work is mainly MIS. It includes endoscopy, tubes, and anterior OLIF approach as well. So this is a case, uh, this is a 75-year male. He comes with a lot of back pain. He presented to us with significant back pain. If you look at it, his VAS is 9 out of 10. So he is really in a terrible, terrible pain. His medical history, he is a case of chronic kidney disease. He's on dialysis. His serum creatinine is 5. Blood urea is 160. He also had a when during the COVID period he had a lung he had some problems because post COVID he developed COVID, and then there was a lot of fibrosis in his lungs. So he is basically a very, very sick patient. Not only a sick patient but also a challenge for the anesthesia, especially if you consider a general anesthesia or something like that. So that is the patient, and if you look at his MRI, he has a lot of compression and there is an infection, and then the posterior you can see there is a compromise. The infection is going right into the canal, and this is power. If you look at it, the left side, the right side is more involved. He has the L3 and L4. The power is 3/5. The left is slightly better, which is the power is 4/5. The challenges here is you have a very sick patient. You can do a lot of things. There could be a lot of options to do of surgeries here. There you can offer him maybe whatever you works with you, but what will be the right thing to do, considering not only that you have to do the surgery, but you need to do it safely. And we had a team meeting where we discussed with the anesthetic and the whole medical team as well. The challenge here, the patient is unfit to undergo any big surgery, including a procedure which involves general anesthesia, considering the circumstances and the things which are involved. So what is your thought process? Do you think what will you opt for? What is your normal, what will your normal line of treatment here, and what will you think, especially considering all the background which I have given you?
Okay, let's discuss. Prof. Max Wu, are you here? If you can share some of your opinion as well.
Yeah, thank you. Thanks so much. I think this case that you mentioned, that's an infection and also the not suitable for general anesthesia. And nowadays, actually, endoscope become a very good option for early pathology detection and also the debridement for the lesions. So I think this case, if I think that would be definitely a good choice to do endoscope earlier. Yeah. So that's my suggestion. And of course, some CD drainage now can also be applied, but I think endoscope is still better. Yeah.
So one more thing, if you look at the level, it is a D12L1, your floating rib, as you can see here, I've already marked. Do you think it will be an issue? When, of course, I think everyone will opt for a transforaminal approach here because that is the most suited. You don't want to go interlaminar in a already compromised spine. So do the faculty feels that it could be an issue when you go transforaminally? And if possible, how will you go about it?
Yes, I think transforaminal will definitely be the first choice. Yeah, so because that can use awake surgery and I think can get the pathology. I think that definitely the first choice. Yeah, I think the rib won't be a big issue. I think in this scenario. Yeah, because it's not above T10. I think at this level, rib is not the issue. Yeah.
Okay, fine. So any other opinions? Anyone thinks differently? And do you think only a decompression is enough? because we can also see some amount of collapse happening here anteriorly. So any other opinion, thought process on that? Because we understand the endoscopy will allow us to do a good dural work and will also allow us to get a good sample here, considering, it's a pathology. But if you look at it, there is some amount of, collapse happening because there's some destruction as well, as you can see on the CT scan. So any thought process on that, or any tips and tricks, or anything you want to add on this?
I think Dr. Narendran Tiran put up the hand. Maybe you want to make a comment? Dr. Narendran.
Thank you very much. I'm new to endoscopy and I've done spine, but my question is that can't you treat this with antibiotic and analgesia, and then once the infection subsides, the bones will reform? Do you really need to operate on this case?
So if you look at the deficit, he's already, how long do you want to wait? His power is already 3/5. He's already, he's having, and look at the compression, especially on the right side. Of course, the traditional is you can wait and everything. And and you need to do a quick sampling and start something. And not only that, there are few issues. The neurology is a issue. The pain is significant, and you need to know the bug. So that is where, like those of us who do it, we believe that endoscopy can, do all the three things. Traditionally, I understand you can give antibiotic, weight, and everything, but if you can help him out of his misery in a safe, effective way, why not go for it? That is my thought process, at least.
Sure, thanks. Thank you. That makes sense. Thanks.
Yeah, Professor Max Wu put up the hand.
Yes, actually, I would like to add on. I think this patient also have osteoporosis, I think. So treat the infection, also need to treat the osteoporosis at the same time. So if I will recommend also for some anabolic agent at the same time may be helpful, but of course it will be a longer treatment strategy. And also second thing, regarding to the stability of this vertebra L1-2. So I think the collapse is still minor. Also is to start to collapse. So I think the initial debridement with the endoscopy still need to be mentioned that further collapse maybe will lead to a second operation. But at this phase, I think the endoscope will be enough. But if you are you're worried about the chance of collapse, may consider to do pedic screw fixation at the same time with the percutaneous method. So that's some surgeon also do that as well. Yeah.
Okay, thanks for your comment. Let's Dr. Sharma can proceed to show us how you solve the case.
Yeah. So basically, we agree with most of you. We felt endoscopy will allow us to decompress the spine cord, which is, there's a compromised cord. We thought we can get a good sample. And we also thought, let's do something, let's provide some sort of a minimum stability, at least considering, the anesthetic, they wanted a quick job in. And I agree with the comments from Dr. Hugh that we started the patient on the anabolics because we felt he's osteoporotic. And we did counsel him that you might need a second surgery later on the stage, considering, the segment might collapse or something. So this is what we did. We went through from the right side, which is the most symptomatic side, and we use a transfemoral endoscopy. And this is how it is. We went in, we could really go, and exactly this is the area we thought the pathology is coming from. And this is the video. It's a remarkable video. The moment you put your scope, you don't need anything. The pus keeps pouring and pouring and pouring. So the moment it was such, and look at the consistency of the pus, which is here. Even if you want to take a biopsy, maybe by small needle, or maybe by if the radiologist is doing it, look at the consistency. It will be very difficult to really aspirate it. It was very thick, condensed pus. And this goes on for, next 20 minutes. That much, how much the dura was, almost like, it was really getting compressed with all the pus that was there. And then we did something which, and of course, it was done under local anesthesia. Patient was talking because the GA was almost out of the question. And we did this also. Not only that we decompressed, but what we did is using the same sleeves, we could pack allograft mixed with antibiotics. So, what at least I wanted some sort of a structural support anteriorly. So we know the sleeve is where it is. And, and you can see this is we did an intraoperative CT to ensure that look at the graft, which is gone. It is really, filling the gap as much as possible. And I thought at least for now we can do this, and let's hope that fuses, because we could not do more than that. And the patient came out to be E. coli, and this is the culture which is positive. We started him on the antibiotic as per the culture, and this is a 3 months post-op MRI, and not only you can see some amount of collapse still, because they always heal with some collapse, but because the graft which was there posteriorly, actually the posterior part didn't collapse. Although you see the most of the destruction was posterior. Anterior, it did collapse, but he goes on to do very well. You can see the canal has completely recovered, the pathology is recovered, and I thought we have a small series with something like this. It is part of the book being published on endoscopy we have written a chapter with Dr. Luke Kim, and so it will be there. So we have now almost 75 cases where we believe that, especially when you have cases like this, where you need to get a good sampling biopsy, endoscopy really gives you a good opportunity. So this was the case. I thought we'll bring something different rather than a straightforward discectomy case.
Can I check your bone graft that you inserted is an allograft or autograft? Okay, sorry,
No, so this is an
I missed that.
allograft. If you look at it, it's an allograft
Mm.
mixed with the antibiotic. So we knew that patient is chronic kidney disease. So they normally have a gram negative. That is normally what happens. So we sort of use something which what our team told can be used. So we mixed it with the graft, local graft, and we could use the same cannula. If you look at this video here, I think we can just insert it. So if you look at it, you can just go, you're already there, and you know that it won't come back because your canal, your sleeve in the C-arm tells you that where you are. And still, anytime you have any doubt that, graft might go back, you can always put endoscope and check, and you stop exactly out there. And if you really punch it very well, as you can see in the post-op CT, this is the intraoperative CT which we have done, it can really make a good, solid, bulk. So this has we have done for a very limited series of cases. It's not that you do it for everyone. Of course, if you have option of putting screws and patient is well and put a cage, of course that is the best. But for a very limited series, especially we did with few of the patients who were post-COVID, we think it has worked well in those limited cases.
Okay, thank you very much. Any further comment or questions from anyone on the floor? Okay, then in the case, we move on to Professor Hughes Harrison Kim's video. He's now on the planes. So I was with him previously for half a year or so together when we do endoscopic fusion. So I will take on the questions. Please play the video and I will answer the questions from the floor. Thank you, Dr. Sharma.
Thank you.
There's sound in this video.
Hello everyone, I'm Hyeun-Sung Kim,
Okay.
President Spinal Endoscopic South Korea. It is my great honor to give a recorded live surgery in APSS. Today I will show the live surgery of the endoscopic lumbar fusion of 2 level. This patient is a 65-year-old female patient with severe back pain and leg pain. You can see here the stenosis 3 for severe and In the X-ray, you can see the severe degenerative scoliosis 2, 3, and 3, 4 here. You can see. I will do the endoscopy lumbar interval fusion 2, 3, and 3, 4 by the endoscopy only. 2 p.m. 30 minutes. But now we will start 2, 3, and 3, 4 uniportal endoscopy lumbar interval fusion. You can on. Firstly, I will starting 2, 3 level. The incision point will be the lateral border of the L2 lateral pedicle. On the middle, yes. On. Okay, now we can see the L2 pedicle. On. 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 Okay, here is the lateral border of pedicle. I use the same skin incision during the pedicle procedures and the endoscopy lumbar interval fusion together. On. 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 I'm the king. Insert the obturator to the medial border facet, and we'll find the Kim's point from the medial border facet to lateral. Spinal dilation. This patient is so sclerotic, and finding the medial border facet is not easy. I actually finding the Kim's point, move to the lateral, and then after drilling the some lateral border facet area, we can see the lateral border facet fold. Okay. Okay, now I find the Kim point here. Okay. Here is the Kim's point. Kim's point means that the tibial SFM cranial tibial facet here. This is very easy to resect the IAP in the endoscope pressure. Okay. I'll check again Kim's point due to the level. That's it. Okay, we checking the Kim L2 level. Here is the SAP, and here is the tibial of Kim point. Here is the Kim point, and here is the tibial SAP and the tibial facet, and resect the SAP from the lateral to medial, like this way. Okay, here is the root point of the medial border isthmus here.
So we wrote an article. We wrote an article on this technique. There's a Wu's point and Kim's point. Wu's point is in the spinal laminar junction. The Kim's point is the lateral part of the facet joint. So we tend to drill across so that we can resect the inferior articular process on block to harvest it as a bone graft. Like
and I will the IAP. Sorry.
This technique is complete resection of the facet joint. So
IAP completely. Yeah.
So we resect the IAP, and then now we look out for SAP for decompression.
And then I will remove the SAP. Firstly, I checking the tip of SAP here. Okay. And then I will remove the SAP. Firstly, I checking the tip of SF here. Okay. Okay, now okay, I will start resect the SAP here. SAP also same method find the lateral border pelvic upper border area like a keystone.
We can see the lateral border of the facet
And
joint
the
between
and the
SAP and
front of
IAP Kim's bone.
the line from medial to lateral to medial.
So we drew quite
And the
close to
medial
the
border
pedicle,
is
just above it, so that then we
no
have
laminar and
reasonable
like
size of
here.
the SAP.
Here is the upper border of pedicle here. And I will ring the SAP here.
So because we drew just at the upper border of pedicle, we can set a reasonable size SAP as bone graft as well.
And then we can go to the final space like this. Here is the final space. Okay. And then you can see the low root here. Here, low here. But I will not further today because people is not final stance is not here. But you can see the disc here. Okay, now clear the final space. Okay, I'm now exposed the final space and disc here, and I will drill the cooling adhesive drilling like this. Cooling adhesive disc drilling is a very important critical process of the endoscopic movement fusion. And using this process, we can see that some collapsed disc will release sufficiently, increase the height sufficiently. Yeah.
Professor Kim tend to use the small 3.5 mm drill to drill the disc space directly. So clearing the adhesion.
I will insert the 1 kg because here is loading is not so much. Sometimes it's not happen so much because I will insert the only 1 kg.
With this technique, we can insert 1 or 2 cage. In this case, we choose to do 1 cage.
I protect the nerve by the working channel, and we will check the medial border nerve using the working channel rotation. You can see here the lateral medial border, and I will direct to here. Nerve root already protected.
So rotating the endoscopic retractor tube, you can actually protect the traversing nerve roots, in this case L3, and then you continue the discectomy.
After some mild drilling of the entry points of the water body, you can see the border of the end plate and water body. So then you can separate end plate from the water body.
So using a pen fill, endoscopic pen fill, you can, in this case current, you can separate out the end plate from the disc, preserving the end plate in the process.
What's that? I also can separate the caudal border of the end plate from the vertebral body. Okay, the 2-3 space is sufficient to insert the KG. I'll move to 3-4. Dura is now intact. Okay.
You can see the nerve root is intact and place well prepared.
Okay, now we expose the foraminal space here. And also here we can see the nerve root is free here. Now, here. Okay. Here.
So you can see the exiting as well as the traversing nerve root. It's not all cases we need to see both, but in this case we can see both.
Okay, 3. Okay. Here is the medial border of foraminal space. Okay, we can see the all endplate denudated sufficiently accurate.
You can see it's very well prepared. One of the strength of spinal endoscopy infusion is that you can prepare the end plate almost like how we do ACDF with a complete resection, complete end plate denudation, really clear on the amount of end plate preparation. Now he inserts a dilated tube and he has designed a Harrison cage glider. We have published about 2 or 3 papers on this cage glider as well as the dilator together. So you can read it on the journal, how we insert it, and this how we insert it. This done under fluoroscopic guidance. The cage glider is in a way that we can protect the traversing and exiting nerve roots.
I'm now insert the obturator. It has a 3 effect. First, we keep the safety, and second, dilation of the collapsed disc some more. And also, third, I can check the KG disc height. Usually, this obturator can adapt it to 11 disc height. Maybe this patient, I think that maybe we can insert 12 disc height. 12, and now we can see that great 12 and degree 4. On.
After that, we insert the bone graft.
Through the safety working space.
He used allograft, and some of the autograft we harvested. Most of the autograft is used inside the cage.
The safety obturator. I will insert the obturator again. On. Still, we keep the safety, and then we can withdraw and change it to the Harrison glider. And this Harrison glider, some centered to the midline, and it protects the nerve traversing and connecting together. Because of the first we insert this not nerve area, but in the vertebral body area and rotate. Firstly, insert and touch the bone now, then rotate and push it. On.
So you
Now
put
we
in
can
this way,
perform the
parallel to
adjustment.
ankle, and then you push all the way into this space.
Then
Now
I
the
will
traversing nerve root is protected.
It's degree 4. Currently in Korea, we can use the 16 degree and 16 disc height, but this patient is a 12 degree, degree 4 is sufficient.
It's
Insert,
L23, so use a 12
and
degree
I've already
lordosis.
touched the bone on. You can see it inserted good area on.
So you can see the cage entering in.
After some insertion, I can withdraw this on and adjust to the angle on. Now we can see the cage insertion is good and dura is intact. Okay, here. What's that?
You can see the traversing nerve roots is intact. The cage is in the correct position.
Dura intact. Kicking root. Also, no exposed, meaning that it's intact. Okay. I'm now inserted drain.
So then we insert the percutaneous pedicle screw. After he does another level to correct the deformity.
Finally the skin suture we're doing the skin bond, not suture, only bond. And with the we insert anti-pain drug to a subcutaneous space. So see the time, we spent 2 hours 30 minutes from 2-level endoscopy movement to anesthesia. Thank you so much for your kind attention.
So this is the final X-ray. The deformities well corrected, and you can see the post-op sufficient restoration of lordosis. So, is there any questions from the floor? I can help to answer the questions. I'm familiar with this technique. I do this technique sometimes. And we have published a number of papers on this. So, anyone have any questions on this technique? Okay, looks like there is no question for now. I think Professor Kim has demonstrated this technique very good, very well. I think the key point is that this technique involves resection of the entire facet joint, and it gives an option of bilateral decompression as a result. It involves we have a ability to resect both the IAP and SAP as a bone graft. And Dr. Chan, you have a question?
Yeah, I have a question. So actually, I am very impressive on the Harrison cage glider. Very impressive. So actually, in terms of deformity correction and achieving complete fusion, I'm still endoscopic surgery still faces several limitations, especially in the deformity correction and achieving complete diffusion. So, Dr. Kim, what aspect do you think needed to advance in the future to overcome these challenges?
Actually, the interbody fusion we published in several papers is not inferior to microscopic. Personally, I've been doing this endoscopic fusion for a number of years. I use BMP and I don't have a problem with fusion. I do every patient a 1 year CT scan, and there is interbody fusion. I think the trick is for me is okay. I've subsequently switched to bipolar. I have a lot of bone, and then I pack it in front with BMP in front of the cage. When I insert the bone and the BMP is not under saline, it basically is dry. And then we switch on the water for a while just for the insertion of the cage, which also has BMP, and then we switch off the saline again. So personally, I don't have a problem with interbody fusion, although it's not new. I mean, we have been hearing this criticism, or not say criticism, this comment for the past 8 years, because we have done that for the past 8 years. But it is a fairly common. I think people who do endoscopic fusion have to be very wary of the fact that your saline can wash out your bone graft. And this cage glider also help in a way because during the insertion of cage and bone graft is in a dry situation. But when I do biportal, it's under a little bit of saline situation. But I think if you keep it reasonably dry, it is okay. Thank you, Dr. Kim, for the comment.
Thank you.
Okay, if there's no more comment, it's probably we just on time and we let Professor Kim Yong-Chan to end the sessions with his summary statement.
Thank you. That concludes what has been truly enriching afternoon of advanced spinal endoscopy from cervical spine and all the ways to the lumbar region infection or the OIL. So I want to convey my sincere gratitude to all the speakers and the case presenters and our moderators for sharing their expertise and contributing to such a successful session. A special thank you also to the APSS Online Education Committee for their meticulous organization. And also please look out for announcements regarding the next APSS webinar program, which will continue to delve into cutting-edge spine topics. Finally, for those who are not yet members, I strongly encourage you to register as an APSS member. Your membership provides access to our ongoing educational resources and support to the critical mission of the APSS. We look forward to continuing this conversation and sharing further advancement in the future. Thank you very much, and good afternoon to everyone. Thank you.
Thank you.
Thank you so much, Professor Kim. Thank you so much, Professor Wu. Thank you so much, APSS. Thank you.